Okay, we've had an exciting morning session. I think we've had a great lineup of keynote speeches that we've really covered. And when I talked to a lot of people during the break, they were really appreciative about the different insights that you could gain about the healthcare ecosystem. What is it that consumers expect? What is it that service providers in this space could possibly focus upon? And how do you really integrate all of these approaches towards something which is a universal kind of a platform? And that's where now, with an amazing break that we've had in between, let's get back to our session on hand. This day ahead promises to be equally interesting because we have a great lineup of speakers as we go along. Now, before I go ahead onto that, a lot of people told me that they missed out the Energizer that we did when we did TiECon. How many of you attended TiECon in April? Okay, some of you all, any which way. And we had a great Energizer that people really appreciated. So I'm going to use that back again out here for each one of you. It's very simple. It's just about you following instructions that I tell you. That's it, nothing else. So we're going to be using a sequence of yogic exercises that is putting together your hands. Okay, it's a yoga exercise, just putting together your hands, but you have to do it in a certain particular sequence for it to work effectively. Okay, are we good? So I'll just demonstrate the yogic sequence. It's a great yoga sequence that helps to energize you. Okay, so the sequence goes 1, 1, 2, 1, 2, 3, and then Pune. So let's try it again. 1, 1, 2, 1, 2, 3. Pune! No. The energy has to come out. One more time. 1, 1, 2, 1, 2, 3. There you go. Now you are all focused and energized and in the same place and time as all of us out here. Let's go on to our post-tea session right now. And to start this particular session, we have someone who is the promoter managing director of Metropolis Healthcare, a reputed chain of diagnostic centers with a loyal customer base across India, South Asia, Africa, and the Middle East. For the last 17 years, she has been focused on delivering sustained growth, built and led corporate functions, including finance, strategy, business processes, optimization, innovation, investor relations. She is named among Asia's most powerful women in business by Forbes Asia and 50 most powerful women in business by Fortune India. She is recognized as a global thought leader in the healthcare industry and also played an instrumental role in changing the pathology industry landscape in the country, from being a doctor-led practice to a professional corporate group in an extremely unregulated, competitive, and fragmented market. She received a degree in finance from the University of Texas, Austin, and has also completed the prestigious Owner-President Management Program at Harvard Business School. Please put your hands together for Ameera Shah, the promoter and MD of Metropolis Healthcare.
Hi, good morning, everyone. Really happy to be here and honestly very happy to see a completely new set of faces. For the last 17 years, every time I've been in any healthcare association, speech, organization, all the different FICCI, CII, Nat Health, etc., you always see the same faces. And you start to feel a little bit jaded because, everybody says the same things every year and then you come back 5 years later and they're still saying the same thing and you're asking for regulation from the government. So it's really nice to see a very fresh group of people who are actually tackling the same problems of really wanting to make healthcare something very different, something scaled, and something of good quality and sustainability in India. 17 years ago when I started building Metropolis, we were one of the few ones to disrupt it at the time. Pathology, just to take you back those many years, pathology at the time was all about walking into a very small lab of 50 square feet, 100 square feet. There was dirty blood and cotton on the ground. There was a smell of spirit in the air, and it was, nobody was wearing gloves. You really didn't know whether you were actually going to get an infection and then leave, or whether actually somebody was going to take your blood. And it was not exactly the most clean, hygienic, professional, pleasant experience to go through. And we thought to ourselves and said, look, this can't be it. I mean, I had lived in the US and I said, this can't be how we're really getting diagnostics done. And while Metropolis even had a good quality reputation then, we really wanted to see, can we build something different? Can we move away from this mom and pop standalone pathology lab concept to really building a branded, standardized chain of pathology labs where people know I can go to Bombay or I can go to Chennai or I can go to Delhi and I'm going to get the same report when my blood sample is given. Can we offer every variety of tests that's available across the globe, whatever it is, and be able to really, again, give it in a manner that you trust. And that's how we really went about building Metropolis, and it's been step by step. So, being the disruptors at that time, it's very interesting to now see a new set of disruptors in the industry who are now trying to want to say, look, why can't we make pathology and why can't we make healthcare work differently? And I truly applaud that because I think each of us can only be as good as our competition and the market. And as long as we've got new ideas and innovation coming in, I think it makes everybody really get on our toes and work harder. I think healthcare has been a very interesting journey in general. A lot of people talk about how the future of healthcare is going to be disrupted. I personally don't believe it can be disrupted completely from an external force. Healthcare is one of those industries which requires a lot of changes to happen within it for it really to be disrupted in a classical sense like we've seen happening with the e-commerce guys or with other technologies. And I think the reason for that is because I think fundamentally in healthcare, really on the ground, the gatekeepers are the doctors, right? Whatever we may say, whatever we want to do in the digital world, whatever we want to do in a conceptual frame of mind, the doctors are the gatekeepers. And even if you take an example of what's happened in other parts of the world where new healthcare startups have gone in and tried to introduce new ideas, unless you get the doctors on the ground to buy in, to adopt, to actually agree with what you're doing, it's very difficult to actually be able to scale it. So in my opinion, it's the brick and mortar guys who are going to be able to incrementally move forward and hopefully disrupt themselves and disrupt the industries. Because at least I don't personally see it coming as an external force from outside completely changing it. I think there have been a few people in India who've tried to do it. Time will of course tell whether it will really work, but I think where the opportunity for investors, for entrepreneurs is, I've seen a lot of young entrepreneurs in healthcare over the last 3 to 5 years. And I think initially it was all about the excitement of, oh, we can build a consumer business in healthcare. And I think 9 out of 10 guys who came to present to me would come and say, I want to build a B2C business. And I would tell all of them, I said, listen, if you want to build a B2C business, great. But why does a patient come to you? What's your credibility? Right? Just because you're offering a discount, that's great, you'll get a bit of business, but then how are you going to sustain? And really, what is your service USP that's going to allow you to be different? And honestly, none of them had any USPs in their business models. It was the very cookie cutter, I'll go and offer diabetes monitoring online with graphs and charts and I'll give them discounts. And that doesn't hack it. In my opinion, the startups, the healthcare startups which are coming with interesting technologies need to actually partner with existing brick and mortar healthcare delivery companies and say, look, how can we really adopt some of these technologies to bases and patient bases which already exist? Because building that trust and credibility with patients is a very long-term journey. Education and healthcare, I think, are the two industries which require huge trust building, and that gestation period takes time. It doesn't happen overnight. We can't force it. We can't throw money at the problem. We can't buy customer bases. It just doesn't work. And if it does, it works for a very temporary period. But if there was a way to get the new innovation, the new products, the new services that guys are building through interesting technology and build it onto the existing basis of brick and mortar, I think that combination can be really deadly. What I don't see happening today is the brick and mortar guys don't have necessarily open, flexible technology products and platforms to be able to integrate and adopt new solutions. And the startup guys obviously don't always have access to the brick and mortar guys to say, look, how do we come together? But I'm convinced that healthcare in this country can only really build to the scale that we want through this sort of integration. And definitely not stand alone. Each of us trying to, hit the problem separately and getting into our own small bases. I really congratulate platforms like this that are bringing the old, unfortunately I'm right now in the old category, the old and the new together, and to say that, look, how can we make something really interesting out of this? If I was to talk about diagnostics very specifically, it's a very interesting industry because it's one of the industries where your client, your consumer, and your customer are completely different, right? Your customer is actually the doctor who prescribes samples, who prescribes the patient. Your consumer is the patient. Each of them has their own different agendas. Each of them has their own different considerations when they're choosing as to which diagnostic partner they want to go to. So it's all about, diagnostics is all about balance. It's balance of services and processing, manufacturing. It's a balance, so therefore you have all the problems of production and manufacturing, of quality control, inventory, supply chain, logistics. You have all the problem of services, which is the front-end training, the attrition, the retail, all of that stuff. It's a combination of retail and wholesale. And it's a combination of introducing new technologies, but not introducing too many technologies. And the reason I say that, and when I'm talking about this, I'm talking about medical technologies. The reason I say that is because diagnostics as a business is basically a business of economies of scale. You make money when you're running enough volume of samples through enough batches. The minute you start running very small batches of samples, this entire business model falls apart. So if you have, like we've got 4,500 varieties of tests today. That's an enormous number, and that's probably as many as the largest player in the world has in terms of variety of tests. But what that means is that I'm running a batch of every one of those 4,500 samples, regardless of whether I have the volumes to be able to actually make it economical from our perspective. If everybody starts doing that, you're just not able to make it feasible. So therefore, it's about not adopting every technology and every test that comes, but again, finding a balance between doing just enough, but still upgrading yourselves so you stay a pioneer. And as we know, in healthcare, there are always the underlying shadows. There's always the underlying shadows of, is there corruption? Is there a nexus? Is there, are those kind of challenges, and how do you really break through them? As an organization, we've actually always taken a stand of saying that if we build our business in an extremely ethical manner, and in an innovative manner, where we're not actually getting into any nexus with any parties, right? Be it doctors or be it otherwise, then we actually have the ability to stay ahead of everybody else. The reason for that is because if everybody else is going about doing exactly the normal practice, which is of finding financial ways of incentivizing people to send business, at some point when this market becomes clean and when this market becomes regulated, they've relied so heavily on getting business through either discounting or by financial incentivization that actually they're not able to stand on their own feet and do it without those things. So we believe that if we do that from day one, and we're not reliant on anything but the excellence of our services, but the innovation, then actually long term, when this industry does get regulated, does get cleaner, does get ethical, we'll be the last man standing. And I think that's been our approach to really building this entire business. And honestly, that's the one thing that makes me sleep very peacefully at night. A lot of people ask me and say, oh, what keeps you awake at night? I said, honestly, nothing keeps me awake at night. Business will keep coming up and down. That's life. And that's the journey of business, right? There'll be some good years, there'll be some not so good years. I don't worry too much if our EBITDA is a few crores less and a few crores higher. What worries me more than anything else is if we land up giving, by any mistake of ours, an incorrect report to a patient. What worries me really is if tomorrow people are saying negative things about the company's reputation. If we are not taking care of all our stakeholders with fairness, with respect, that concerns me. Because I think if we're in the business as entrepreneurs long term, then I think we have to look at it long term, and the biggest asset in healthcare as a long term is your reputation. There's nothing else. Your reputation is, to me, the biggest asset that we have as a healthcare organization, and we've got to protect it with our lives. That means not only from a quality perspective, but also from a reputation of being a fair organization and having a purpose behind all of it. I think we've seen in my journey of the last 17 years, I've been through a bunch of investors. We've had 3 different private equity, had ICICI Ventures, we had Warburg Pincus, we have Carlyle now, I've had KKR as a structuring partner for debt, I've had other investors, we've seen boardroom battles, we've really seen a lot of the soap operas that you normally imagine happening in business. And it's been, as an entrepreneur, a very interesting journey because, as I always tell people, that entrepreneurship people think is about a financial journey, or entrepreneurship is about a business journey. And really it's not, it's an emotional journey. At core of it, it's an extremely deeply emotional journey because there's nothing like entrepreneurship to actually teach you your deepest flaws, the things that you lack the most. It reminds you every day on your face as to what what is lacking in you, because your reflection and your personality reflects totally in the organization, especially when you're a small business. If as a person, I'm not an organized person, I'll find my business being chaotic. If as a person, because that's how I operate, and the people down the line will exactly do what I'm doing. So, you know, as an entrepreneur, our personality is totally reflected in our businesses. And I think that's why it becomes really important emotionally that we manage ourselves to become as balanced, the best versions of ourselves as we can, because that's the only thing that will then allow the business to become the best version of itself. And to me, that's been really the core of it, and staying very true to the purpose. And you know, a lot of people at least ask me and say, look, what's your sort of purpose of building this business? And you know, what is the number goal that you have? What are you trying to reach in 2020? And honestly, while we have our financial models and we have our numbers and our Excel spreadsheets, that is genuinely not what is driving us on a day-to-day basis. I think what continues to drive us on a day-to-day basis is making sure that we're impacting the lives of the patients around us in a positive manner. And how do you judge that? How do you really ensure that you're doing it in a positive manner? And I think in healthcare traditionally, we've always paid a lot of importance to doctors. But unfortunately, the patient has always been swept under the carpet, because somewhere the mindset has been back to the customer and consumer. The customer is the doctor, and the patient is just the consumer, and therefore will, you know, get what they get. What we've tried to do actually over the last many years is try to put the consumer at the heart. The patient is king. The patient is the most important person in this entire cycle. Because if the purpose of what is driving the organization is all about making an impact, a positive impact on the patient, then we have to put the patient's interest first. The doctor's interest comes second, our interest comes second, our financial interest comes second, our investors' interest come way back there. What comes first is the patient interest. And that's much easier said than done. Because we function in such an unregulated market, you have so many fly-by-night operators. You have so many people doing exactly what you want. Just to give you a statistic, in diagnostics alone, we are estimated to have 100,000 labs in this country. Anybody want to warrant a guess as to what percentage of these are actually accredited, where there are some minimum standards to operate? Anybody? You'll be shocked, right? There are, out of these 100,000 labs, 1 lakh labs, 1,200 are accredited, which means almost less, 99% of them and more are actually completely without minimum standards and without any accreditation. And just to remind you, these 1,200 who've gotten accredited have done so voluntarily. We've opened our doors and say, hey, please come check what we're doing and give us a stamp of approval. Now, usually you'll know people who are opening their doors and say, hey, come check what I'm doing are usually the ones who are following some good practices. So the question is, what's happening to the rest of the 99,000? Nobody knows whether they do the test. Nobody knows where they get equipment from. Nobody knows where they get reagents from. Nobody knows anything. And patients, the government, doctors, all just assume that they are doing the right thing. And that is really scary, because who's getting compromised? The patient. We see so many cases where patients will come to us and say, oh, I got this test done at XYZ lab. I went to the doctor, and the doctor said, I can't make a decision based on this report. And they have to do it again, and they have to do it again. And we see poor patients like this, get cheated out of money on a daily basis. So I think one of the things that we've obviously been doing is trying to work closely with the government to say, hey, you need to put minimum standards. Forget regulation, but at least put a minimum standard for a lab or a hospital or any delivery service to be able to actually operate in this country. Because without minimum standards, you're comparing apples to oranges, right? Which is where, of course, there's been a lot of conversation around Ayushman Bharat and really how this is going to play into healthcare. My personal opinion is, from a citizen perspective, of course, I think it's a wonderful initiative. I think it's really unfair if the poor of our country are not given access to healthcare. So I think as a citizen, extremely happy that the government has made this initiative. And I'm really looking forward to people having access to good quality healthcare. Having said that, there are significant challenges, right? The most significant challenge is exactly what I just mentioned. There's no minimum standards. So while we may create access, while we may pay for services, without minimum standards, you don't know what quality you're actually giving to the patient. So you might create access, but you're not necessarily creating minimum standards for a certain level of healthcare. Is this going to lead to more complications? Is this going to lead to more deaths because of healthcare? Likely. Is it going to lead to a lot of fraud? Very likely. Because our technology and IT systems are just not geared in the provider network to be able to manage this. I mean, I remember when demonetization happened, how easy was it, right? You found one guy who had lots of cash under his bed, would go and pick up, 100 farmers in his locality and give each of them 2 lakh rupees and say, go put it in your bank account, because that's the permissible amount. Why are we not seeing the same thing happening here? It's going to happen, right? You'll have one small nursing home who says, look, I've got 50% capacity, and let me figure out a way that I can fill this with Ayushman Bharat patients. I'll get the signatures of the people that each of them got certain surgery done, and voila, I've suddenly made, got 50 surgeries extra per day. So I think without the technology platform, we are headed in a direction where we will have access, we may have people being provided services, but as a domino effect, it might suddenly start to fall apart. Because unless patients are getting a certain quality of standard, and unless people are getting paid their money, providers are getting paid their money, and the government is not getting cheated, unless all these 3 pillars work together, I think scaling the initiative will become a significant challenge as we move forward. But I'm very excited about the market and the size of the market that this can create, and really the opportunities that it's going to create for new businesses, new entrepreneurs to come in and be able to fit into this much larger scope of what we see as the Indian healthcare industry, which has just been too shallow for too long. I'm just going to wrap up by saying that as an entrepreneur, as I mentioned, you want to focus on balance. And I've tried to focus on balance between 2-3 things. One thing is always focusing on balancing between the short term and the long term. A lot of the times people will tell you, oh, build for the long term. That's 100% right. And one of the mistakes that I made personally was not building a good enough team very early on. As an entrepreneur who had less money, you start to build and say, okay, I'll build just enough for where I'm at. And that becomes a huge challenge once you've come to a certain size where your quality of team is just not good enough to take you ahead. And that was one big mistake which I made many years ago. I wish I had built a better quality team earlier compared to what I've built today. So one is focusing and balancing between the short and the long term. But the second is actually balancing between paranoia and caution and aggression. People think paranoia is a really bad thing. I think paranoia is actually makes entrepreneurs great, because it's only entrepreneurs who will wake up early in the morning, stay awake late at night, saying, oh my God, this guy's catching up, he's catching up, I need to run fast, I need to do something. And I think that paranoia is very healthy if it's not taken to an extreme level. So the balance between being paranoid and at the same time being aggressive and being positive, I think is another thing which has really aided me along the way. I'm very proud of the business that me and my team have built over the last many years. And I really want us to continue to focus on patient first, ethics, quality, and respect as really the fundamental values that are going to drive us as we move forward. And I truly hope that a lot of you guys in this journey will also pick up some of the same things and be able to focus on the patient first. Thank you so much.
Thank you. Thank you. One sentence that you used resonated with me, helping people become the better version of themselves. I think that's what exactly TiE Pune does. And we definitely do not have sleepless nights because you know what is the value that we really impart to the startups. And you've done a wonderful job in sharing your values as well as your approach. We'll have a quick round of questions. Again, people who need to go on the mic, please do not introduce yourself. Just ask a very crisp question.
Are you already adopting the value-based care model over fee-for-service?
So currently it's a fee-for-service. However, it's a very transparent fee-for-service. And I'll tell you today, if you look at the challenges that I think a lot of the hospitals are facing and the backlash that they're facing from people as well as the government, the reason is actually not so much pricing. The reason is actually non-transparent pricing. Because when you walk into a hospital, you actually don't know what bill you're going to walk out with. And that's the fundamental issue, that people have no visibility and no planning around what the cost is going to be to them. At diagnostics, like with us, when you walk in and you're ordering a service, you know exactly what the fee is. So before you're actually deciding whether you do it or not, there's complete transparency. So to me, actually, the big change is going to be about building transparency in healthcare.
My question is about advent of technology in diagnostics especially. Do you see a danger of doctors starting treating reports rather than doctors treating patients?
I think in the US, we of course see that a lot, right? Because of medical liability, you see doctors wanting to protect their backsides with complete diagnostics, which means that, by the way, the diagnostic chains in the US for every sample have an average of 12 tests. In India, every sample has an average of 2 tests. And the reason for that is because doctors are actually careful in India about prescribing diagnostics. And the fundamental reason for that is the patient affordability. They don't want to burden the patient with too many tests. They don't want to be accused of being in nexus with the diagnostic center. And they care genuinely for making sure that the patient is not getting bankrupted in the process. So I think this thing in India will continue for a while longer. I don't see the report-based diagnostics becoming a norm here. I think Indian doctors have used a lot of their clinical judgment, I think, which is a very positive thing.
We'll have the last question.
That was questions really. How your work about minimum standard setting with government is coming up, and is it a reality anytime soon? B, are you, till the government comes in with regulation, are the bigger players in diagnostic planning to collaborate together and kind of come out with their self-regulation, because the restraint is the best regulation? And C, as a practicing clinician day in and day out, I have to explain to the patients what eukaryosis is and what is NABL and why some lab charge more for the same test than the others. Are the labs working in patient education for that?
Thank you. So first point on whether the government is moving towards minimum standards, although I would love to say yes, the answer is no. There is a lot of conversation around moving to minimum standards. There has been a bill which got passed in Parliament, but unfortunately has been left for voluntary adoption by states. So therefore the states have chosen not to voluntarily adopt it. So therefore we continue to live in the same space that we've been in the last 15 years in diagnostics, no change from a regulation perspective. I am truly hopeful that this will change in the next 3 years. And if it doesn't, then I'll be back on the stage saying the same thing, unfortunately. Second question in terms of whether there's patient education happening and whether there's self-regulation. Actually, the only way we've built this business has been through self-regulation. Because in the lack of regulation, we decided that, you know, if you look at sort of a lotus that blooms, it usually happens in lots of mud and dirt. So we decided that, look, if the industry is chaotic and not clean, let us be the lotus that blooms in it through self-regulation and restraint. And that's going to be our model of growth. And that's exactly what we've done. And I would say that's I don't want to comment on my competitors because that's not fair, but we for ourselves have definitely done that. Patient awareness and education is always a plan, but you know, when you're talking about the large number of people that live in this country, and the small scale of businesses that we all are at, I mean, the ratios are just ridiculous. So even for companies like ours, we spend a lot of money on patient education. We don't even hit the tip of the iceberg. So unless the government actually comes in and makes it a priority to say, hey, we want to start building patient awareness about quality, about guidelines, about information, about their own health, preventive health care, I don't see this changing anytime soon.
Okay. We'll have a last question because as entrepreneurs, no one wants to miss an opportunity, but make it brief and crisp.
Just comment. Please identify 3 major roadblocks you're finding leveraging digitalization into your path labs.
I'm sorry, 3 roadblocks in?
Leveraging digitalization into your ecosystem. Yeah. 3
Sure.
major roadblocks in India today.
Sure. Yeah. I think number 1 is the brick and mortar area continues to be the primary revenue generator. And in that being the primary revenue generator, most of the teams and the bandwidth is still stuck, I would say, for most organizations in just pursuing that brick and mortar growth, and therefore less time to focus on new initiatives. That's number 1. So lack of bandwidth and lack of talent in the industry. Number 2, I would say the technology systems and platforms, even in the larger players, have not been flexible and open to be able to always adopt new technologies and fit them in seamlessly. And the energy and effort required to be able to do that is not always, sometimes people think worth their while, they would rather build. So that's sometimes the second. And third, most importantly, doctors have not adopted digitization. So unless the gatekeepers adopt digitization, even if all the periphery does it. Finally, I'll give you a simple example. We have patients who will call us at 6:30 in the morning to their house. They're sitting in their pajamas at their home. My home visit technician will reach them. They have ordered it on a mobile app, not called us. My guy will reach them. He will do the entire thing in 10 minutes. The report has reached them by 12 in the afternoon on email. completely digitized, completely this. But at the end of the day, when the patient goes to the doctor, they have to still print that report. We have to send a hard copy, and they'll go to the doc. So the gatekeepers, as I said, are the docs. Unless that changes, the habit changes, I don't think the industry will change.
Any quick comment?
Thank you.
How
Thank
do
you.
we convince these clinicians?
I'm sorry?
How do we convince these clinicians faster?
How do you convince clinicians? I will leave that for Dr. Malpani to come up here and address.
Thank you. Thank you. Can I request one of our charter members, Sunil Peswani, to please come up and present a memento to Ameera Shah? Good.
Excellent presentation.
Thank you. Thank you.
Thank you. Thank you, Ameera. That was a wonderful session. From consumerization of healthcare delivery, let's look at now healthcare game changers. To conduct this session, we have someone who's an entrepreneur with interest in the healthcare delivery, social enterprises, and tech-enabled health startups. He is the founder of Vatsalya Healthcare, an award-winning social enterprise, which was the first network of hospitals focused exclusively on the Tier 2 and Tier 3 towns in India. He is passionate about healthcare access and is now deeply engaged in building a right to primary health movement across the world. To support health startups, he also leads Disrupt Health, a health-focused ecosystem enabler based in Bangalore, and is actively involved in this sector as an advisor and an angel investor. He's been recognized as an Economic Times leader under 40, a young global leader 2012 by the World Economic Forum, young leader by Asia Society in 2011, and senior Ashoka fellow in 2010. He has a medical degree from Karnataka Medical College and a master's from the University of Houston, Texas. Please help me welcome Dr. Ashwin Naik. Can I get this mic on, please? Switch it on. Yeah, it's on.
Thank you and good morning. I think after this wonderful talk by Ameera, I'm at a loss to figure out what to add, but I'll try anyway. So, if I were to summarize what I'm going to share today, I think one sentence might be enough, which is think outside the hospital, right? I think we have to start thinking outside the hospital if we have to disrupt the healthcare sector. So that's the big message. But let me come back to why I say so. So if you just think about how hospitals came about, right? What is the genesis of hospitals? How did we come to be a hospital-centric healthcare system? Maybe we have some lessons to learn and figure out the way forward, right? So there were 2 or 3 major things which happened over the course of history. Number one, and I think some of you might know, the religious institutions many, many years ago didn't have women, were not allowing women to participate either as priests or etc., priests or members of their churches and things like that. So the first entry of women into the church was as nurses, right, to take care of people who were terminally ill. And that is how people started coming to these institutions, which then subsequently became hospitals, right? So hospitals were designed for people to go and die peacefully. Nothing much has changed over many years now, but this is one of the pieces. The second thing, which I think is much more critical, is the advent of anesthesia and sterilization practices. Right? By these 2 things, by figuring out anesthesia, you could do many complex surgeries, which meant that multiple doctors can work together, right? The surgeon, anesthetist, etc. So now you are forced to bring all these people into the same building, and hence this concept of modern hospital started. The other thing which is also, I think, linked to this whole idea of bringing specialists together is, this is traditionally how we train our doctors, right? I think our field is one of the few fields where everything is done by apprenticeship. The junior doctor sees what the senior doctor is doing, and we learn that way, right? Now, if you look at these three things, right? Places where people go to die, definitely we don't want hospitals to be that. Places where complex things are being done. And we heard Amira talk about how things are being sort of mechanized, reduced in size, and many of the tests that you do today were done in hospitals and diagnostic labs earlier, but you can do many of those tests at home. If you look at surgical procedures over the last 20, 30 years, we have also seen that many complex surgical procedures have either been converted into a medical procedure or have become very, very simple that can be done in an outpatient type of setting. And the third piece, which is, I think, still a big problem, is how do we train doctors? And this model of bringing them to a specialized place and learning by observing, I think, is one of the limiting factors. And with technology growing in terms of e-learning tools, etc., maybe there will be a day where people can learn on their own, and medical education itself can transform itself. So given all this, the shape of the hospital, as we know, is changing. So that's my whole thesis, that let's start thinking outside the hospital. And one of the bets that I like to make is maybe in 30 years, we don't have to go to a hospital, obviously, to be healthy, right? So I started looking at this and said, who are the people who are already thinking outside the hospital? Which are the companies around the world which are thinking along this line, and what are they doing? And so those are the healthcare game changers that I want to share about. But I also found that while we were looking at these organizations, all of them seem to have a few common principles, and maybe for you it will be interesting, so I'd like to share those. The first one is, in these organizations, everybody plays. And I use an analogy of a game because it illustrates this. Now, in medical sector, Amira used a very nice term called gatekeepers, but I think I have the liberty to say this. The problem with healthcare is the doctors, right? Because it's driven by doctors, one, expertise, and two, ego. Because we believe that we know best and we have to tell everybody else what to do, right? Even if you look at the language used, doctors' orders, right? That everybody else has to follow. So all the other people in the ecosystem, nurses, technicians, your psychologist, whoever is there, ends up playing a secondary role. So the healthcare game changers that we are looking at, everybody steps up, right? Nurses are playing a more active role, psychologists are playing a more active role, and to some extent, the doctors are playing a supportive role and not the front end. One example I would share is a company in the US, many of you might have heard, Iora Health, which is creating this health and wellness approach to healthcare by deploying teams of people who take care of your healthcare needs and supported in the back end by doctors. And the team has a psychologist, a nurse, a nutritionist, and maybe a nurse practitioner. So that's one piece, which is everybody plays in this game. The second pattern that we saw was these healthcare game changers are expanding the playground. And this is, again, very central to the idea of think outside the hospital, right? How do you provide care for people in a very easy, accessible manner where they are, in the school, in colleges, at their workplaces, at their homes? And in India, we have already started seeing the home healthcare sort of movement emerging. But can we push that, right? Is it possible for us to access care where we congregate on a daily basis? One example that we saw was from Japan, a company called CarePro. They do all your health checkups at the subway terminal, right? The Japanese train stations. And one interesting fact of this is when they started doing these tests, they hit a very interesting bottleneck, which is that you cannot take blood of a client to do a test unless you are a registered nurse. And then suddenly they had this big problem that they had to hire registered nurses and this cost would go up. So they were almost thinking of quitting this business, but somebody came up with this bright idea that there is no regulation about clients taking their own blood. So all they had to do was design a tool for patients to take out their own blood and hand it over, right? So now you don't need a registered nurse because that process is done by the patient or the client, and then you can do this test. So things like this. So people are bringing the tests close to where we are, where we live and work. The third principle that we saw is that they invite new players, right? One of the challenges that we have in healthcare is that we are so ingrained in our own thinking, again, driven by doctors and expertise, that it's very, very resistant to change. And in that sense, I disagree with what Amira said, is I think we need a big shakeup. Somebody has to come from outside and say, forget all the existing rules, let's start from scratch, right? And define something which works for all of us from a health perspective. I think the sick care model, which is driven by doctors, I think needs to be optimized by doctors, but keeping us healthy might be disrupted by people from outside. And one example for this is how, the recent news of Amazon and the other two partners coming together and trying to figure out how to crack healthcare. My hope is that they'll come up with some great ideas which will force the existing healthcare system to think more innovatively. The last piece I want to leave with, I don't know how much time I have. Do I have time? Okay. So the last piece of these healthcare game changers is they believe that they are in the business of changing mindsets or changing the rules of the game. And what do I mean by that? I think traditionally we have always thought of healthcare as a transactional service, right, that we have to deliver. Even when we think about health, we are always thinking about, okay, let's go and do something, right? But how do you go and change the mindset so that when you leave, things continue to go, right? One example is an organization in the UK run by this gentleman called Mark Swift. They have come up with something called social prescribing. So the doctors, if you go to the clinic in the GPs to certain practices in the UK, they can prescribe you Zumba dancing, right? How amazing is that? Zumba dancing, organic food, and they have a network of people. It's almost like you are prescribing something to go to a pharmacy. And then you have people who are able to support that prescription or whatever advice that you have given. So really changing the mindset that, we are not coming here to do a transactional sort of service, but more for your health and well-being. So these are some of the principles that I saw in the healthcare game changers. But really, I think the message is how do we think or start imagining a world without hospitals and think outside the hospital. Thank you.
Thank you, Dr. Nayak. I loved the last part when you spoke about how the ecosystem could be broadened and bringing Zumba dancing also. I'm imagining next year's healthcare summit. And I'm imagining all the people that can be here because you widen the scope of the healthcare as it is. So we'll have now questions. Again, repeat, do not state.
Thanks, Ashwin, for the great talk. Quick question on the definition of health that WHO has, where they've included mental and spiritual health, and which goes back to the whole prevention and, as you said, sick care versus health care. Some countries like China have moved to 30% traditional Chinese medicine now.
Yes.
So how do we bring the ecosystem of large companies, like one of the ones that I work for, Philips, Medtronic, Danaher, to sort of start going in the direction of healthcare with monetary incentive-wise, I don't know which way we can do that, and also focusing on the non-physical health aspect.
Yeah, I think the definition of WHO has been around for many, many years. I think we're just beginning to acknowledge it, right, as a healthcare industry. To your point about how do you incentivize medical technology companies, doctors, anybody in the ecosystem to start thinking about health as defined by WHO, I think the biggest challenge today we have is a perverse incentivization system, right? We are paid, we make money. We have to wait till you fall sick, right? And that's when we start making money. So how do we change this incentive? And there is a very interesting Chinese example of this from the 14th century, I think, Ming Dynasty. They used to employ doctors, the king used to employ doctors, and the doctor will get paid as long as nobody in that village falls sick.
Yeah.
Right? The minute somebody falls sick, a part of your revenue is gone. Right. So you're incentivized to go to people's home, check whether they are drinking clean water, eating properly, exercising, and things like that. So I think the first thing is to change the incentive system. The second is also, not to say this about Philips, but it's hard to innovate in a large organization like that. I think startups will come in with a sort of a clean slate, maybe will push the thinking more, and then Philips can adopt it and scale.
Sure. Are the insurance companies the kings of today who will be able to ask the ecosystem to make sure that everybody is healthy?
I don't know. I think it's a very tough question here. I don't know the answer. Because insurers are again, in the business of managing risk. I don't know how it will translate. Maybe there are better experts who can address that from the insurance side.
Yeah, hi. Very good afternoon. I would like to thank you for emphasizing on very important topic, getting healthcare outside the hospitals. We see a lot of people globally working in community health centers, e-pharmacies, telemedicine, telehealth, and getting healthcare outside the hospitals. My question is, how about the Indian market, where it is very stringent, very traditional? We see people are opposing e-pharmacies, doctors are opposing community health center. Can we really get healthcare outside the hospitals?
Can we is not the question, should we is the question, right?
Yeah.
So I think if we were to focus on improving health, there is no other option. I don't think any number of new hospitals, adding more beds and all that will not do anything. I think there are already enough initiatives, both from the government and the private side, who are thinking about this. One is, with whatever limitations we have, home healthcare has been a great sort of shock to the system, right? Putting services very close to your homes and bringing that service to you is the first step, and it started in the private sector. On the government side, actually it's much more progressive with this whole concept of health and wellness clinics. The entire focus is this: how do we bring these services as close as possible to the community? And 150,000 health and wellness centers are being set up. There are states where primary health centers are being repurposed as health and wellness centers. I think that's a good start, right? Okay. And then there are certain set of services which have been identified, and hopefully they'll be implemented as planned. I'm hopeful that between these two we will start to see, and I think the most important sort of driver of this will be all of us. We have to start asking this, demanding this service, both from the government and our healthcare provider.
Sure, thank you so much.
Sure.
Dr. Ashwin, can you talk about your book?
No, I just did. This whole thing was about the book.
Okay, thanks.
I have a quick question. You are talking of taking healthcare to the patient, or doctors to the patient rather than the other way around.
Right.
There is also an incentivization to increasing the number of doctors, reducing the ratio of patients to doctors, etc. Right. Do you see any risk in commoditizing the entire medical profession to the point where people will not be incentivized to have it as a profession? And it becomes unsustainable in terms of certain financial and quality of life.
That's a very interesting question. First of all, I don't think we need to take the doctor to the individual homes. We need to take a healthcare provider, right? It could be a nutritionist, it could be a nurse, it could be somebody, right? And the definition of who is a doctor will also change, right? Today, it's almost like, a doctor today is almost like a priest or a religious leader before printing press was invented, right? Everything is in my head. You have to come to me, then I decide, right? But with more and more people having access to the tools, information, and decision making, I think that expertise will also become less how should I say, specialized, right? And then more and more people. So I think in the next 20, 25 years, the definition of what a doctor looks like, acts like, does, will change dramatically compared to what we have today.
Okay, we'll have a last question.
As this improves access, the disrupt health model, how do we ensure quality?
Yes, so one of the things that we have to build from the ground up on this is how do we, number one, start with the right standards and then continuously monitor them, right? I think one of the challenges we have today in our sector is that there is a formal organized medical community and then there is informal medical community which is almost 3 times as large, right? Technically, we can solve the doctor problem by co-opting all the non-traditional practitioners. But the challenge is how do you maintain a standard of care and quality? I think that is partly regulation and partly making sure that there is transparency in the data that comes out, right? Whether it is outcomes or things like that. It's a long haul. I think it's going to be fairly intense process to bring all of this together, but hopefully we'll start somewhere and pick up the other piece.
Okay, wonderful.
Thank you.
Thank you, Dr. Ashwin Naik. I'd now like to request one of our other charter members and the convener for this conference, Darshan Doshi, please present a memento to Dr. Ashwin Naik. Good. Thank you. Incidentally, you will go back for the next session too. So the next session that we have now is flipping the picture and looking at the other side of the story too. We're now going to talk about how is technology helping hospitals to deliver better care. And for this session will be moderated by Dr. Ashwin Naik, whom we've already met and we've introduced him. Our other 2 panelists today include Colonel Dr. Sunil Rao, who has 32 years of managerial experience in hospitals and healthcare industry. He is currently serving as the Group CEO of Sahyadri Hospitals and has previously served as Senior Vice President Operations at Columbia Asia Hospitals and as Director Hospital Projects in the Army Headquarters, New Delhi. He has expertise in planning and executing projects with a flair for adopting modern technologies. He received the award of JCI for CA Yeshwantpur and award of NABH accreditation and JCI for the hospital. Thank you, Dr. Sunil Rao, for joining us. Our second panelist today is Dr. Suchin Bajaj, who is an MBBS MD. He is also the Chevening Gurukul Fellow from the King's College of London, an IHT Fellow from INSEAD of France, and also an Aspire Fellow. Dr. Suchin Bajaj is the founder director of Cygnus Hospitals. He is an avid healthcare investor and is associated with multiple health tech companies as investor, board member, and mentor. He is on the TBIU board of IIT Delhi and is also a member of the advisory council to the Minister of State for Health, Shri Ashwin Chaubey. He is the winner of the Healthcare Leader of the Year 2017 award. Thank you, Dr. Suchin Bajaj, for joining us. Over to you, Dr. Ashwin Naik.
Thank you. So welcome, Dr. Bajaj, Dr. Rao. So maybe we'll start with a quick introductory remarks from both of you and your views on technology and healthcare services. And then we get into a quick conversation, but more the dialogue between the audience and us, which I can help facilitate.
Yeah. Let me start by thanking the organizers, Dr. Viraj Vaidya, who happens to be my good friend, and because of him I am here today in this panel discussion. So, in terms of opening remarks on how technology is helping hospitals in delivering care, as all of you are aware that in this century, the many technologies which came in various fields, whether it is in the curative field, in the operative field, in the process fields, and also in the delivery of healthcare field. And the previous session, Dr. Naik was also explaining about how the technology is helping in terms of taking this healthcare to the home. So that's a new field which has started evolving. I represent the sector which is more formal, probably from the hospital side, more focused on the curative aspect, and also from the point of view of cost-effective delivery, because all of you are aware that the healthcare is, suffering from this particular aspect, that lot of embargoes, lot of restrictions have come from the government side in terms of making, you can say, a lot of profits, which probably industry was used to making a lot of profits in terms of healthcare. And that's why a lot of PE funds and a lot of finance people were interested in putting their money into healthcare, which is slowly probably is getting more and more rationalized, to the extent that we are seeing a lot of consolidation which is happening, and we're trying to take help out of volumes rather than banking on indecent profit margin, which I would say, which were there earlier. And slowly we are rationalizing the healthcare towards a cost-effective healthcare. The biggest example of it is Ayushman Bharat, which has been launched recently. And we at my hospital group are trying to see what best we can make out of Ayushman Bharat in delivering good care to below poverty line people, as well as orange card holders, etc., what government is proposing. So our focus essentially is delivering healthcare with the technology which will be cost effective for our country and for people at large, rather than helping only very few people who are on the top of the pyramid, I would say. It's mainly our attempt is to see that the technologies which we should put forward, or we should propose, or we should encourage, is to see that we can participate in the larger scheme of the government, which is now called Ayushman Bharat. But apart from that, in the large interest of the community. With that, I think I will hand over to Dr. Bajaj.
Thank you very much. When I saw the panel today morning, actually I was a bit surprised, thinking that, what were the three of us doing on a panel on healthcare technology, like Vatsalya, Sayadri and Cygnus. I think we cater to the most deprived of communities. We are mostly social enterprises working in small towns, catering to the poorest of the poor, and not really employing, at least I can speak for Cygnus, we are not really employing any very high-tech cutting technology to treat the patients. But then I started thinking about it, and then, as we saw in the earlier presentation as well, there is no healthcare without technology, right? Right from thermometers to ECG machines to CT scans to MRIs. Healthcare has taken to technology very quickly when we have found clear value in it. The graph may have been slow because we are by nature risk averse. Even a small mistake can cause, a patient's life, and we as doctors do not take any risks whatsoever. Even a 5% risk is very, very high for us, which, as was pointed out earlier, is not so in the money market. And they can make you lose your money very quickly, so can make changes quickly as well. So technology is an integral part of what we do. I have started out as a clinical person. I was a physician, and I've had, I still have memories of waking up at 2 o'clock in the night to hear a phone call saying a patient has chest pain, his ECG, something is wrong, but we don't really know. So why don't you come and see? And I would wake up 2 o'clock, drive, go to the hospital and see a normal ECG and reassure my medical officer that don't worry, everything is fine, this is a normal variant, and you also can go to sleep and let me go to sleep again. And now with the advent of WhatsApp and pictures, it's so easy. They can send you CT films, they can send you pictures of the ECG and they have a discussion with you. So we adopt technology very quickly when we see clear value. It's just that the problem is, as has been spoken about many times, as a healthcare investor, I get a lot of pitches. Every week I get 10 pitches. And most of them assume that the doctor is resistant to adopting this technology, and they will tell me that we are working on this to make sure that the doctor does not use it at all, and we'll bypass him completely. So we forget that, the healthcare ecosystem started with only two people, the doctor and the patient, right? We've built so many things around them now that this hospital that, Dr. Ashwin has very clearly told us, there are hundreds of people around these two people. But if we want to break it down, if we forget these two stakeholders, then it's not going to work. So as Dr. Balsari also said in the morning, all the EMRs are made with the CIOs, the CTOs and the finance people. Right? So whenever we implement an EMR, we've done 3 of them now, unfortunately. We have to change every time. So when the EMR is implemented, our technology officer, our finance officer and the HR person, they'll sit down, the feedback form, very good, excellent, excellent, it's wonderful. And when the nurses and the doctors fill out, idiotic, stupid, very bad, takes a lot of my time, it's horrible. So these are the feedbacks we get because nobody has sat down with them and really asked them what is needed. So if we sit with the doctors and the nurses and the practitioners and develop the technology, I think they will take it up very, very quickly.
Thank you. Thank you. I think just a follow-up on this question, and I'm sure a lot of startup entrepreneurs are asking this question, is what is the right way to sell to you guys, right? Because I think every time an entrepreneur comes to this point, when they start talking to the promoter or the doctors, they always come back with this sort of notion that A, they are not technologically open to adopting new ideas. Second, it also seems that the decision making is so long and so convoluted. So from your own experience, what has worked for startups who have approached you guys?
I think making the minimum viable product is the best way to do it, right? If you have an idea, it's not really important. We have thousands of ideas every day, and hundreds and thousands of people have the same idea, trust me, right? Holding the idea close to your heart that, oh, I have this brilliant idea which, will change the paradigm of healthcare delivery, it's not going to work. So the first thing that you should do is try and implement that idea and see where it is going. Do it with 5 patients, 10 patients, 2 doctors, 5 doctors. Build a minimum viable product. See what the problems are. Keep switching it day in, day out, day in, day out. Right? I don't know if you've heard the story of Mr. Langley. I don't know if people have heard the name of Mr. Langley. If you're flying into the US, you'll get into an airport which is called Langley Airport. This guy was the huge guy in civil aviation, right? Apparently. So the US government gave him $1 million grant and asked him to build an aeroplane. He built 2 seaplanes with that $1 million grant with the best team he could find. Took a year to do it. And those 2 seaplanes obviously did not fly. One sank overnight, one flew for around 10 feet and then sank. And the next day, the New York Times had this big story saying it will be 1 million years before humans take flight. Around 20 days later, the Wright brothers flew. Nobody had heard of them. And here now everybody has heard of them, right? Because they had this minimum viable product which they kept changing every day. They failed every day, they built a new plane, they failed every day, they had their homemade tunnels. They could afford failure because that was very, very small. But they did build a product which flew for a certain time and then people could scale on it. So approaching an investor or a promoter of a healthcare company with an idea or something that promises to change the paradigm or, build around the doctors, it's not going to work. Have a minimum viable product ready, show that it creates value very clearly, and we will jump onto it, definitely.
Thank you. Thank you, Dr. Bajaj. Dr. Rao?
Yeah. We've had a lot of experiences, rather, people approaching us for various things. I will give our personal examples. For example, in physiotherapy, there's something called continuous passive mobilizer. many of you may be knowing. So this was produced by one of the startups at 50% of the cost at which people are using from US and UK and various other products. Similarly, in occupational therapy also we have developed some products with the help of people like you and the community like you who have helped actually Indianize it. So it may sound little different coming from us being a private group, but we also have a huge patients who are below poverty line and those who are orange card holders, etc. We also actively participate in this Mahatma Phule Jana Arogya Yojana and various other government schemes. So we always are in search of such products which are cost effective and which do the same job. See, many times we argue with many of engineers and those who are developing products. What is heart-lung machine? It's after all a pump, right? Why do we need 55 lakh rupees for making such machine? Okay, so things like this keep on coming to our mind all the time when we deal with poor patients and when we know that patients cannot afford it, whatever said and done. Many things which come to our mind, many of you are helping. For example, the other day we have developed a hoist which lifts the patient because we are also a neuro center. So we get a lot of patients who are neurologically disabled in terms of quadriplegics or paraplegics, and all those patients need help in every time they do some movement, there is a need. So one of the local entrepreneur actually developed this hoist machine which in UK and in US etc. costs a bomb. Many of you must have heard a company called Hillrom which produces this hoist machine for patients because they cannot move on their own and they have to be moved every time whenever they need a help. So this was developed at, I can tell you, at a very, very low cost. And it is working quite well for us, for our setups. So things like this, we would definitely encourage all the entrepreneurs to come up with such solutions which are Indianized, which are at ground realities. That is what I think at large government is also trying to do when they say make in India. I don't know how much successful it is, but we keep trying for such type of products to be made available so that overall everybody gets benefited, is my take on this.
Great. Thank you. Let me just build on your comment here. How important is this cost factor, right? Because what happens is when you are innovating something, right, and it's not like you are miniaturizing or re-engineering it. Many startups are now focused on novel things, right? So cost really becomes an issue, and most hospitals start with this question: I have this solution, how much will I save, right? Is there a move from there saying that this cost might be okay, but we are focused on better outcomes, better ideas, etc.?
I think cost is a very relative and subjective term. So it's, I think, more kind of bang for buck. How much can you get out of it? How much extra value you can create by spending this money? How much better outcomes can you make? So cost is just one of the factors, but I think even if it's a very high cost per se but creates value that is 10 times, I think that it has to go from there. Money is definitely important. It has to be sustainable. We cannot keep putting in money to implement a solution. At the end of the day, it has to make money somehow for organizations like us.
It is also, as he said very rightly, Dr. Bajaj, that quality is equally important. But at the same time, we all are aware about our economic situation and our affordability to various things. So I am very, very, very happy that many of our entrepreneurs are, very much aligned to this aspect that, what we need for today. It also, as he said very rightly, should be sustainable. See, many of the entrepreneurs do give you the products which you can use it at a low cost, but they are not sustainable. Many times they are not able to maintain them. They do not understand the basic principles on which it is working, and ultimately we land up in a product which we tried to develop, and then we later on, come back to the same thing that it would have been better if I would have gone for an imported product, patented technology, etc. But notwithstanding that, our attempt is to bring in newer and newer technologies at a minimal cost for our patients. There is no doubt about it. But definitely from entrepreneur side, they have to also make sure that they are sustainable.
Great, thank you. I think we heard very interesting thoughts about adoption of technology, cost versus value, the importance of iterating fairly rapidly when you are building a MVP. We'll open up for questions. Please keep your question very short, and if you want to address it to one of the panelists.
Hello, yeah. I'm Dr. Banerjee here. I'm a medical administrator. So I've been here the whole morning. I just want to make a couple of comments about some of the things which were said. One is a lot of discussion about EMR and whether it's proved to be clinically useful or not. But we're missing the point, no one talked about the fact that doctors have the worst handwriting in the world. I'm a doctor myself. And all said and done, financial benefits, legal benefits, business benefits set aside, the UAE government has already said that handwritten prescriptions are illegal. And a couple of days ago, the government of India is also debating something similar. Indian Medical Council, MCI, had also said that doctors must write in capital letters. Doctors will never write in capital letters.
So is your question...
I'm saying EMR should become the norm, if for nothing else, at least for the legibility factor. That is one. So, and I know that many doctors hate EMR, and we are dealing with it all the time, but it's the future. That is one. Second comment I want to make...
If I may just
interrupt. Yeah, please.
Let's just keep one question per person, so everybody gets an opportunity, and maybe an opportunity to respond.
Yeah. We, on Dr. Banerjee's comments, especially on medical records, we, as everybody knows, the doctors are resistant in writing down. So we are trying various new solutions for this. As a practical experience, I would like to share that, as we write, we ask our doctors that, do you write or you don't write also? So they say, yes, we write. Then we will give you a pen and a pad on which you can write like normal pen and paper. So they have started adopting that, and it is getting converted into the records. So this, I thought I will just share this. There are very many solutions which are available today, which can have the same effect as electronic medical records. And in fact, it is better that they write in their style so that we come to know that this is the doctor who has written this, and that is becoming more interesting for us as an organization to analyze it in a better manner.
Yeah, dictaphones have been around for a long time, and if you see American practice, they have had a lot of times where doctors have been dictating their notes, and a medical transcriber then changes it. So I am working with a company which actually is trying to do voice recognition for these on-the-round notes that the doctor needs to write in every file and after seeing every patient, because the only thing that the doctor is resistant to is not actually keying in, it's the time that it takes to key in, right? He can just scribble a note in 2 seconds, but to actually go to the EMR, and as was pointed out in the morning, it took him 3 minutes to remove a stitch, but 20 minutes to write the notes about the stitch on his EMR. So that is the problem Indian doctors mostly have, because the regulations are not so tight that he needs to put everything into the EMR, whether grudgingly or not. But he has no time. He has to see many, many more patients than an American doctor. So if we can save some time for him and create value, he will definitely want to write in it. It's the only thing is, the value is not clearly visible to the doctor right now, that why should he write in the EMR, whether it is a penal value or a positive value. Neither of it he can see right now. So if he can see it, he will do it.
Okay, so we'll take one last question, please.
Sure. So my question is for both the panelists. How much of best practices are typically used at the hospital? So when I say we can take an example of average length of stay, which is one of the very frequently used concept in US and most of the developed countries. Do we have something similar that is happening in Indian healthcare ecosystem, and how diligently we follow that? For example, if the average length of stay for a patient is 4 days, do we literally follow that thing, and can we correlate with the quality of care that has been delivered to the patient?
So I would like to respond as a professional myself and also as an organization, both ways. See, average length of stay has a different connotation for different diseases and different specialities. For example, for a neurosurgery, the average length of stay may be around 5.5 days or 6 days. And for a cardiology cases, it may be just a 1 day. Or for ENT, there may not be a day stay also in the daycare operation. So these things depend. So it is for the medical professionals to understand these nitty-gritties as an administrator and then act on it. As you said very rightly, are you following all this or not? Yes, we do follow, but this also is a departmental matter. For example, neurology and neurosurgery people would definitely have a red flag if the patient is staying beyond 7 days. So that is the way we function generally as a community. But at the same time, as an individual, I would like to comment that to take a gross thing out of it, like from a finance point of view or from a point of view of pure medical administration person, is difficult to follow, because practically there are many things which have cropped up. Now, for example, just to give you an example, and all of you are already aware, many of you are doctors also. So the antibiotic resistance which has started developing puts off everything. You can imagine a Ayushman Bharat patient staying for 2 days extra will spoil your complete financial situation, financial equation. This is happening day in and day out. So there are many multiple factors which have sprung up because of resistance, because of ARDS, because of many other factors. The length of stays are getting totally, going haywire.
So is there a standardization across the healthcare hospital industry just from the benchmarking perspective?
Maybe we can take this up offline. I think I see the red sign flashing in front of me. In the interest of time, thank you for your enthusiastic participation, and I want to thank the panelists for your insightful comments.
And you too. Can I now request one of our charter members, Amit Paranjpe, to come up and felicitate Dr. Sunil Rao. And can I request Sachin Oswal to felicitate Dr. Suchin Bajaj. And thank you, Dr. Ashwin, for having seamlessly handled and moderated this session. Thank you very much. Thank you. Okay, so now we've seen the perspective from the hospital side. It's also time to change tracks and move on. But I sense the energy in the room has gone down. Am I right or wrong? So what do you need to do? Yeah, yoga. Absolutely. Let's do it. I hope you remember. Let's start. 1, 1, 2, 1, 2, 3. Pune. Now let's do it together. Okay? There, you're getting the hang of it. You're becoming yoga masters by now. Let's move on to another very interesting session, which is on innovations, investing, and mentoring, a doctor's perspective. To conduct this session, we have a consultant IVF specialist who runs one of India's leading IVF clinics along with his wife, Dr. Anjali. They have founded HELP, the Health Education Library for People, which is India's first patient education resource center. He has authored many books, including How to Get the Best Medical Care, successful medical practice, patient advocacy, giving voice to patients, decoding medical gobbledygook, using information therapy to put patients first, and patient safety, protect yourself from medical errors, all of which are available online. His passion is patient empowerment, and he believes that using information technology to deliver information therapy to patients can heal a sick healthcare system. He is also an active angel investor. He invests across all domains and admires entrepreneurs because they have the potential to change the world. Please put your hands together for Dr. Aniruddha Malpani.
You know, one thing I must say, I'm very impressed by the organizers because we're actually running on time. And trust me, that happens so rarely in a conference, so full marks for that. But I think this is what typically happens. Maybe most medical students, you know, this is what you do. You have 5 years, you have so much stuff to cram. And this is what most medical students spend their time in lecture halls like this. What's ironic is this is a modern lecture hall, but it was exactly the same 50 years ago. So ironically, medical education has not changed, though everything else in the world has changed. And because it's not changed, this is what our impression of most doctors are. You know, we have our head buried in books and we do whatever the books tell us to do, but we're not able to do anything more, which I think is a bit tragic because this is one of the worries which doctors also have. And this is one of the commonest complaints, I think, which entrepreneurs have, that doctors are not technology friendly, that doctors aren't able to understand all the clever new innovations which they come up with. Just one quick question. How many practicing doctors, I'm not counting medical administrators, I'm not counting people with degrees who are doing something, how many practicing doctors are there in this room who actually see patients on a daily basis? Okay. I think just 1, 2, 3, 4, 5, maybe 6. I think that says a lot about what I think is wrong with the healthcare ecosystem, because if you're talking about innovation in a healthcare ecosystem and you don't have doctors in a conference like this, how are you ever going to be able to implement any of those innovations? I think the reality is doctors are comfortable with a lot of medtech advances, long list, EMRs, apps, chatbots, you pretty much name it. But a lot of them get very uncomfortable and unfamiliar, especially when it's new. When you're trained, it's not a problem, but otherwise, you know, I'm seeing patients, I have 50 other things to do. How do I manage some of these new innovations? And I think this is something which is extremely important. We keep on talking about the importance of reinventing doctors, but I think sometimes that's a little bit unfair to doctors as well. And let me tell you why. How many of you would be comfortable in this situation? This is a modern operation theater, and doctors handle this kind of technology day in and day out. My limited point is doctors are not idiots, which means if there is a reason they're not using the apps or the technology or the EMRs you're providing with them, it doesn't mean they're technologically challenged or they're Luddites. Maybe there's something wrong with what you're providing them, and I will come back to that again. Would any of you have the guts to operate on a patient using this instrument? You guys are all engineers, right? You're all techies, you're comfortable doing this stuff. But again, this is something which doctors do all the time. And that's true, you know, they're comfortable with high-tech stuff. This is what a modern pathologist would do, looking at slides on a screen. And there are lots of applications which people are using. You're using smartphones at a stethoscope. You're using smartphones in order to look at what the eye. So if doctors are comfortable using technology and you have all these advances, does anyone want to answer this question? Because, you know, I mean, I'm sure we've attended all these conferences, and whether it was 5 years ago or 10 years ago, we seem to be hearing the same things again and again. And I think the reasons are, one, big problem, is that techies are so much in love with their product that it's so obviously better than what that stupid doctor is doing in his clinic that it's a no-brainer that the doctor is going to use it. Guess what? The doctor is not using it. So what does that mean? The doctor doesn't have a brain, right? Because he's not using it means something's wrong. I think this is a big problem, and I'm going to keep on coming back to this again and again. You know, whatever you develop as a minimal viable product looks great when you're sitting in your little air-conditioned office developing stuff, may not work so well. And this is sometimes why This is what I call the graveyard of clever health tech products. Because the reality is, this is what a doctor sees in Indian hospitals on a daily basis. If this is what he is doing, he's got 10 patients, he's got a pen and a paper, he's got a where is he going to get time to look at a tablet, to look at notes, to do these things? And unless you're going to be empathetic and understand what a doctor's problems are, you're really not going to be able to fix them at all. Let me warn you. This is what a typical Indian hospital looks like. Now, yes, it's a challenge, but you know what? For all you clever entrepreneurs, trust me, it's a huge opportunity. Do you know why? Because no Silicon Valley entrepreneur is ever going to create a product for this kind of setting. Because he has no idea that hospitals like this exist in other parts of the world, whereas you as entrepreneurs, because you live in India, are able to do that. For heaven's sake, play to your strengths. Take advantage of what you can do, which other people can't do, and learn to do a better job. But it's not just the setting problem. How many of you are aware of this Google? Google is the smartest company in the world, right? We all know that. And therefore, diabetes is a common problem. You need to keep on monitoring blood sugar levels all the time, but patients hate having to poke their sticks. So they came out with this great smart contact lens. All you need to do is put the lens and then you'll get a blood sugar reading. But guess why it didn't work, anyone? Because someone realized after 5 years, after spending millions of dollars, that there really isn't any sugar in the tears. Which means even though it's a great idea, if you lose sight of your basic biological facts, you're not going to be able to come up with any product which is going to be clinically useful. So what's the solution? I think it's an amazingly simple solution. And this is what I'm going to be focusing on in this talk. How can we get doctors to innovate? Doctors are bright people, would you agree with me? You need to do reasonably well in 12th standard or your NEET or whatever else in order to be able to get into medical college. What happens to them in those 5.5 years of medical college? How do we kill their innovation, their creativity, their ability to think out of the box? And this is what I'm going to be focusing on. This is what we really need to do. I think talking to dinosaurs like me is really not going to help much. You know, we're already set in our ways. But the young doctors, the junior doctors, medical students, these are all digital natives. They live on their smartphones all the time. How can we make use of that? So that's one. And this is what our focus is. You have young, intelligent, technically savvy medical students. How can they come up with these solutions? But you know why this doesn't happen? Because guess who teaches these young digital natives in medical colleges? The digital dinosaurs, the medical professors who are very comfortable with what's in their medical book, but they are not comfortable with anything happening anywhere else. So what questions are going to be asked in the exam? The questions which the professor is comfortable with. What is the syllabus going to be like? This is what I studied 10 years ago. This is why you continue studying the same thing, because that's what's relevant. Ironically, I must tell you, I'm an IVF specialist. I didn't learn anything about IVF when I was in medical college, hardly surprising because the first IVF baby was just about 5 years old. So I'm just trying to tell you how quickly things change. This is one of the things we're really proud of. This is the Medical Innovation, Creativity and Entrepreneurship Lab, the MICE Lab as we call it, which we've set up in JJ Hospital. This is in partnership with the state government, and this is what we're trying to do here. It's a hands-on tinkering lab. We've all heard of Atal tinkering labs in schools. You want students to tinker with their hands. Why deprive medical students? If students can do it at the age of 10 and 12, I'm sure medical students can do that. And this is really what we want to do. And obviously, it makes sense that innovation should start from where the patients are. And this is where the hospitals are. Lots of great things happen when you allow innovation to happen in a hospital setting. The commonest complaint a lot of engineers have is we don't have access to patients, we don't have access to doctors, how do we get into the operation theater? And guess what? You do it in a hospital, all these problems are automatically solved. You have cross-disciplinary collaboration, you have medical students, you can invite engineers and designers so they can come to where the innovation is going to happen. And lots of different fields could then come together and think about what is appropriate for an Indian situation. Simple things like long wait times, can you do queue management better? Can you just have beacons in a hospital so that illiterate patients don't get lost and they find their way to the right thing? Simple solutions. Equally importantly, and I think this is something which is often tragically missing, is because this is where you have your patients and this is where you have the patients' caregivers, you can invite input from them. You can say, look, tell us what we're doing wrong. Tell us what we can do to help you have a better experience when you're in hospital. Simple message, innovation should start from the bedside, because obviously that's what you want your innovation to be used for the patient. So that's where you need to start. And hospitals have easy access to patients. And not just that, you have senior doctors who will provide you with the mentorship. And once the senior doctor takes ownership that, yes, I helped to contribute to this product, doors will magically open, because then this senior doctor will become an ambassador, an evangelist. He will take pride in his creation. He will talk to 10 different doctors in medical conferences saying, this is a new cool product, this is what you should be doing. I think it's really quite simple. Doctors understand the pain points of their patients, but we feel very powerless, we feel very helpless, because we're forced to deal with the solutions which the engineers come up with, and we don't understand how we can create these solutions. So A, we feel paralyzed, we feel helpless, we're very good at complaining about the solutions which engineers come up with, but we're still not capable of coming up with our own solutions. That's the problem we're trying to solve. How are we doing that? There is this great organization in IIT run by Professor Ravi called BETIC, and he says there are 4 Ds for medical device innovation. First is you define an unmet clinical need. What is the problem which you really need to solve? And guess who's going to define unmet clinical needs? The doctors who are taking care of the patients. They can tell you, I'm not happy with this. You then actually design prototypes in the mice laboratory, where you have engineers, you have interns, you have designers. So let's do something, let's put it together and then see what happens. Once you've got your prototype, you then deliver it to the bedside. So you have a quick iteration. This works, this doesn't work, this is terrible, nurses aren't going to use it, patients hate it, whatever you like. And finally, you can then deploy it in the market. That's what our goal is going to be on a long-term basis. But that doesn't mean that we want doctors to start becoming engineers. I need you to understand that. We are very happy for engineers to remain engineers. We're very happy being doctors. We love taking care of our patients. I think the emotional gratification is great. But I think this is the most important slide in my presentation, is that the way a doctor looks at the world is very different from the way an engineer looks at the world. When a doctor sees a patient with a problem, he goes back to his medical textbooks, maybe he talks to a professor, maybe he goes on Google and tries to find out, okay, is this pattern matching? Whereas an engineer will think up a clever, innovative way. How can we get doctors to start adopting this kind of thinking is what we're trying to inculcate. And the right time to do that is when they're medical students. So this is what the mice lab is. This is in partnership with one of the companies startups have invested in called Bibox, which actually sets up Atal tinkering labs in schools. And they've set up over 100 Atal tinkering labs in schools. And my challenge to the founder, Sandeep Senan, was, if you can do it for school students, why can't you do it for medical students? And he's so excited about it because, you know, engineers want to be able to help people. And he has so many of his engineers who are clamoring to want to work in the mice lab, saying, what can we do to help patients get better? But of course, the reason I put up this slide is when you eat an elephant, you can only do it one bite at a time. It's still early days. We just inaugurated this in partnership with the Maharashtra government on the 5th of September. So I don't, you know, I'm not saying we have any success stories, we have anything else. We don't even expect us to have it. This is really what the lab looks like. It's very modest, it's very small. We have simple stuff like 3D printers, robotic kits, stuff like that. And we'll gradually keep on building more. This is more a proof of concept. We haven't earned the right to win as yet, but lots of clever ideas have come up even within this 1 month. Let me just walk you through some of them. This is all very obvious. You might say, what's the big deal about this? No one's saying it's a big deal, but these are the problems which nurses and caregivers face when they have incontinent patients in a ward. So can you put up a simple thing like a bedwetting alarm so that the patient doesn't soil the bed, or when he does, it gets changed? Simple stuff. What happens if you have paralyzed patients? There are all these clever sensors which could be used perhaps to make that person's life easier. Very basic, very simple, but I think this is the starting point for being able to progressively make it better. Again, you know, you've seen these nurse rounds. You heard someone talk about the history of the thermometer, but is it possible for us to be able to do it on a more quicker basis so that the nurse can do other things with the time? This is such a simple concept that if you need to move the patient from, let's say, the trauma to the CT to the MRI, is it possible to be able to do it on an automated basis so that it saves the patient time and it saves the ward boy time as well? Again, simple thing, all you have is a gesture mounted on the bed so that in case there's a problem, it's a simple remote alarm that the nurse knows that there is a problem. As I said before, all these are simple prototypes, proof of concepts, and now we're hoping that medical students will take this up, will start partnering, and will actually be able to deliver stuff which works. Okay, not bad. So again, this is something we actually did within a week's time. One of the anatomy teachers told us, I need to teach neurosciences and the brain. What can I do about it? Because, I don't know whether you've actually been to an anatomy museum where you have all these frozen sections and stuff like that. This was such a simple thing for them to put up. Again, just a proof of concept. But once you've done this, it's in one sense, wow, that's cool. I wish we could have learned like that. And people will keep on developing it more and more. Maybe at some point we can afford a Microsoft HoloLens to be able to add to some of their enthusiasm. This again was done because we were requested by a professor. We have medical students, we have nurses, we have residents. We need to teach them cardiac life support skills, but we don't have mannequins. Whatever mannequins we have are mechanical mannequins, and the automated ones are very expensive. This was literally put up within a week's time. Again, you may say, what's the big deal? But the fact exists that there is no automated mannequin available in this country right now. You have to import it from Leerdal, and that's extremely expensive. And this is a group of young engineers who've been able to put it together so that you actually have feedback based on whether you're doing your cardiac compressions adequately or not. And if they are adequate, the heart becomes green. And the same thing when you're doing mouth-to-mouth resuscitation. You can see some of these things. Again, none of this is rocket science, but the fact is that you need someone to put these together. And engineers know that these solutions are available. Engineers are happy to find problems which they can then solve. And this is what we're trying to provide for them. So what are future plans? Lots of them. Like I said, still early days, and hopefully I'll come back again next year and tell you what we've been able to accomplish. But we want to have hackathons. The logical place to have a medical healthcare hackathon should be a hospital. Why would you have it in a place like IIT? We want to have workshops where we want to invite design engineers and other engineers and tell us what we should be doing. We want to collaborate with IIT colleges. Effectively, we are giving them access to doctors and patients, which is something which most healthcare entrepreneurs would die for. At some point, we will publish medical journal articles to say, yes, this is proof of concept, this actually works. We want these students to apply for research grants from ICMR, for BIRAC. The money is available. We need these students to be able to think about this, and we want to give them a platform. We want to let them know there's a lot of stuff happening in the outside world. This is one place you can come, and we will help guide you to be able to do it. And hopefully at some point, they'll be able to start applying for intellectual property rights and patents, and we can commercialize some of this. And a lot of this stuff is actually being done in other institutions. This is Professor Ravi at BETIC, for example, in IIT, and we hope to be able to partner with them and replicate a lot of that stuff within JJ Hospital itself. I think the right way to think about Mice Labs is think of it like a social impact startup. That this is something which we are funding. We hope that it will have a long-term impact. A lot of it is going to be proof of concept. At some point, we want to pick the best students. I know medical students are extremely busy. They've got a packed syllabus, but you'll be amazed how excited students are at actually doing something which is not just mugging from a book. They get a chance to do stuff which they don't have a chance to do otherwise. We hope to then partner with Stanford Biodesign and offer scholarships. We hope to incubate startups. There are Atal incubation centers, but all of these are in engineering colleges. Why can't we have them in hospitals? Some point, if we do a good job, we'll have a syllabus. We'll have something which will be replicable. So then we can go to other medical colleges and say, why don't you guys start up labs within your own this thing? Why shouldn't there be labs like this in every medical college? And at some point, Of course, once this, right now it's elective, which means it's only the enthusiastic medical students who participate. But if at some point we can actually include this in the medical curriculum, I can promise you that lots of things will happen, because medical students are very competitive and they want to score well, if nothing else, in the exams. And if they get brownie points for actually coming up with something new, there is so much talent in this country which is just waiting to be tapped, and we're wasting so much of it, which is such a tragedy, and we hope to change that. This, of course, is what the Stanford Biodesign program looks like, and hopefully we'll get there at some point. And really, what we're trying to do is bridge the gap between doctors and engineers. Because let's not forget, all of us are on the same side. We're all on the side of patients. We want patients to do well. How can we get them both talking the same language? Part of the problem, of course, is doctors are conservative, and obviously you don't want a cowboy doctor experimenting on you when he's doing an operation, saying, let me try doing this and see whether it works or not. So basically we say there is in vivo and in vitro. In vivo is when you're actually talking to a patient or doing anything with a human body, be safe and conservative, no cowboy tactics. But when it's in vitro, when it's a laboratory, we need you to be able to start thinking out of the box. Doctors are scared about that. And engineers, of course, they love breaking stuff, putting it together, see if we can do it better. And we need to be able to marry both of these things together. But of course, we don't want to do it at the expense of our patients. And this is the big worry which doctors have. And in fact, whenever doctors use technology or medical records, this is often what they think like, if I do something, it's going to break or it's going to exit, and then I have to keep on doing this all over again. And part of the problem is there has been a lot of hype about all the good which technology can do. And this is the problem, because doctors have burnt their fingers in the past. They're not very willing to trust engineers anymore, especially the older doctors. I've heard all this last 10 years ago. Yeah, I tried an EMR, but it was terrible. It didn't work at all. Or the company folded, or whatever the reason may be. And I think part of the problem is doctors think that engineers don't understand anything about patient care. And I think this is where a platform like this can be so remarkably useful. How can you get them to partner with senior doctors? I think it's great for everyone in the ecosystem. How can you get senior doctors to mentor healthcare startups? How can you get doctors to actually act as angel investors? Because the fact is, there is a lot of potential. Doctors want to give back again, and when you then start talking to young, optimistic, enthusiastic entrepreneurs, some of their optimism rubs off to doctors as well, and we're happy to be able to contribute and do something cool, which is different from what we do in our daily lives. This is a big problem. Where are the healthcare success stories in India? We've been doing this for many, many years. We don't seem to have any Olas, we don't seem to have any Flipkarts. We've had richly funded companies like Practos, but really, where is the ROI? Forget about the ROI for the investors who burned their fingers and are therefore very reluctant to fund new startups. Where is the ROI for the patients and the doctors? What's happened with all that money which has been invested? Unfortunately, the quality of care has still not changed. So you can think about it as a problem, as a challenge. And this is the reason why sometimes people are so reluctant to engage with healthcare entrepreneurs. But honestly, I think of that as an opportunity. Great, whatever has been tried so far has not worked. So what? There are always going to be opportunities, and we need to catch medical students young to be able to implement this, because then their mindset will be completely different once they actually start practice. This, of course, is really what we want. Along with a Zumba dance, the next time, we need to be able to make sure that we can get a happy marriage going between doctors and entrepreneurs, because this is really what we want to be able to accomplish for the future. Thank you.
Wow, that was a great session, Dr. Malpani. Thank you very much. I have one question for you before we have questions from the audience. A doctor is already bootstrapped in terms of completing his education. Now, if he gets into a startup, then he has to be bootstrapped a second time around. What are your thoughts on that?
So the other way of looking at it is doctors are used to being bootstrapped anyway. So 5 saal nahi to 8 saal. But the point is this, is that a lot of what will happen in the startup will be parallel processing. So that while he's doing his education, he's also engaging with it. I think the problem right now is it's being done sequential. We want them to take ownership and say, it need not be, it could be just one day in the week, but that one day in the week could be life-changing, both for the startup as well as the doctors. That's
Thank you. Thank you. Okay.
Dr. Malpani, I'm Dr. Depe. I'm a great fan of you. I read your all books. And it is a very balanced talk that the engineers need to, you can say, the medicalized, and the doctors need to be little bit engineerized. So that balance is necessary. And I was part of the Eli Prasad Eye Institute, Hyderabad, and there the IBM has started their lab, and many big institutes, the many tech companies. So all the startups, this is a very right and sound message that their lab should be with the doctors and not vice versa. It can't be a three-idiot doctor that you are making a delivery in your lab, but you can come in our operation theater and have some rational experiments. Thanks for your message.
Thank you.
Good afternoon, sir. I specifically have a question regarding that mice. When I heard that it is connected with the Atal Innovation Mission, I am one of those innovation people who have been assigned a school. I visited that a couple of times. The biggest challenge I feel is the mindset of the teachers. They still tend to provide the answers to the students rather than provoking them to ask questions. So that is one area which I feel should be addressed.
Can I just answer that in a minute?
Please.
I think what you're saying is spot on, which is why it's not enough just to provide the hardware. We actually provide a mentor who's an engineer. So there's a full-time mentor engineer within this thing who will be able to help medical students to think critically. So it's not like this is what you need to do and this is what the solution is. That's textbook learning. And therefore it's important. And we hope that at some point this will become inbred in the medical students so that when they become senior, they learn to challenge the professors as well. Yes, that's in the textbook, but is that absolutely right? Can't we do it some other way? That's what I meant about changing the mindset. That's why we want to catch them young.
So it will be great if I would be glad to contribute to that in any way. It will be very nice.
So it's learning days for us as well, but I hope that, we want this to grow and we'll be very happy to have people. Please come and see what we're doing.
Definitely.
We're also taking baby steps.
Thanks.
Yeah.
Thank you.
Sure. That's going to be the last question now. Yeah, please.
So Dr. Malpani, thank you so much for that lovely presentation.
Thank you.
Having said that, I want to take some very strong exception to some of the things that you said about engineers on the stage. Two things. Number one, if I, as a and I should mention that in interest of full disclosure, I am an engineer, but I'm really talking about my experience as a patient. Today, if I walk into a hospital, I really feel amazed at what engineers have done for the medical profession. Medical profession wouldn't have been anywhere where it is today without the contribution of the engineers and the amount of equipment that doctors use today. So I think the engineers in this room should get a big hand. But you didn't talk about, there is a whole part of the medical profession, particularly the doctors, who, we've talked about, they are very reluctant to change. There is a there is a huge amount of debate about how much doctors are, motivated by financial returns. That keeps them, motivates them to keep the information in their heads, not share it. Half of the time doctors really are struggling with newer things, and, it's amazing that you didn't even talk about that.
So I must explain, it's not competitive. I'm not saying it's doctors versus engineers. That's definitely not what we want. It's a complementary relationship. We need to trust and respect each other. And just like there are good doctors and bad doctors, there are good engineers and bad engineers. And quite honestly, doctors love playing with new toys as well. It's not like they're not happy to experiment. I'm just saying that if we respect each other, there's a lot more which can be done as compared to having an adversarial relationship, which is unfortunately what seems to be happening today.
I think we'll take the next questions during the break. You could ask Dr. Malpani.
Yeah, I'm around.
This is, sorry?
I said I'm around, yes.
Yeah, he's
you want to keep
around.
people away from their lunch, yes.
Yeah, so this is the most important part of any session, the lunch session. Before we break for lunch, I'd like to invite Advait Kurlekar, one of our other charter members, to please felicitate Dr. Malpani. Please come in the center, no? Thank you, Advait. Thank you, Dr. Malpani. Now, before we break for lunch, quick few instructions. We have the startup showcase happening right in the next room. Please make sure that you go around, visit a lot of startups. There are a lot of medical doctors who have actually founded these companies. Great ideas. The lunch break is till 2 p.m. Please be back in the room at 2. We'll start the session sharp at 2 o'clock again. Thank you very much.